Good evening, everybody. I have slightly changed the title of my topic today, which I think is very practical. Instead of saying diagnosis and management of epilepsy, I have made it as overdiagnosis and mismanagement of epilepsy. How common is epilepsy in India? Many of our patients, they think that epilepsy is very rare. Why only it has occurred to me? There are 70 million patients with epilepsy worldwide, and we have about 12 million in our country. The important point is 70 to 75% are well controlled, even by a general practitioner, a physician, or a surgeon, or anyone. Only the 25 to 30% are the one which are difficult to control, which should be seen by a neurologist. This group must be seen by non-neurologists. Have made the title as overdiagnosis. Let us see why it is overdiagnosis. It is very commonly overdiagnosed, I must say that. The first important differentiation between seizures and epilepsy. Seizures, fits, convulsions, they're all one and the same. It means like there are convulsive movements. It doesn't say it is epilepsy. It is like saying you have got fever. Now, fever can be due to hypoglycemia, hyponatremia, organ dysfunction, etc. When you use the word epilepsy, it is a definite diagnosis. Like you say, you have fever due to malaria, you have fever due to typhoid. Similarly, we say that you have convulsions because of epilepsy. The first point in overdiagnosis, reason one, is any type of seizure is diagnosed as epilepsy. That is the first problem. So how do we make a diagnosis of epilepsy? It is defined as 2 or more unprovoked seizures. So first there must be a seizure, then it must be unprovoked, and there must be at least 2 seizures before we make a diagnosis of epilepsy. All seizures are not epilepsy. All epilepsies do not have seizures. It is an underdiagnosis. For example, absence, complex partial, JMA, they do not have a seizure like convulsion, so they go as underdiagnosis. This is the latest ILAE, Indian International League Against Epilepsy classification. Focal onset, generalized onset, and unknown onset. Further focal onset is divided into many more problems like this. The diagnosis of epilepsy is at once simple and easy. Why simple and easy? Because it is entirely dependent on history from the patient and from the person who has witnessed it. There are no need for any investigations to make a diagnosis of epilepsy. That's why it is at once simple and easy, but because it is so simple, it is overdiagnosed. The reason for overdiagnosis, reason number 2, is inconsistent history. Eyewitness is not available, or patient and relative purposefully they play down the history. Whenever a child is brought with history of seizures in the classroom, I tell them to please bring the person who has witnessed that, and I would like to interview that person. The eyewitness is extremely important. In our country, people who have not witnessed will give you fantastic history. At the end of it, when I ask them, have you witnessed the attack? He says, no, sir, my wife has seen. I said, where is your wife? She's sitting outside. I said, you please go out and bring your wife in. I would like to ask the person directly. So the overdiagnosis is because we are relying on a third party information. Overdiagnosis, reason number 3, is the faith in investigations at the cost of history. Faith in investigation at the cost of his. Now people think that they can make a diagnosis on EEG findings or in the imaging findings and not on the history. So that is the reason overdiagnosis is actually the investigations have increased the number of overdiagnoses. Now I'll give you a couple of examples. A 35-year-old male was found unconscious in toilet with a cut injury on lips with quick recovery. The concerned physician thought, is it a seizure or is it a syncope? He was not sure. So he got an EEG done, a CT done. EEG showed some sharp wave discharges and CT showed a calcified granuloma. So he changed his diagnosis from syncope to seizure because of the investigations. Now this calcified cysticercus lesion is as common as calcified hilar lymph nodes in chest X-ray. So it is not an active disease and this should not mislead or misinterpret the diagnosis. Now a little more history. The same patient, he woke up from sleep, went to toilet, passing urine in standing position, felt giddy and sweating. That much he remembers. Then the next thing he remember was he has hit the commode with a lip injury and regained consciousness. Now this is a typical micturition syncope. How do you diagnose? From the history. If you don't take more history, if you're in a hurry to quickly make a diagnosis and then send for investigations, the EEG and CT in this case is not only non-contributory, but even misleading. Now, let us go back to the approach to the patient with epilepsy. As we already said, the definition is there must be a seizure, it must be unprovoked seizure, it must be at least 2 seizures, and then we come to the diagnosis of epilepsy. Now, is it a seizure? This is where many of the overdiagnosis is done. There are 2 important differential diagnoses for paroxysmal disorders. Apart from epilepsy, syncope is the commonest. The next commonest is the non-epileptic or pseudo seizure. Now another case history. A 12-year-old girl, while in school prayer meeting, fell unconscious, had jerking of limbs, woke up in a minute. So the teacher immediately took the patient to the hospital and said, sir, this girl had fits while she was in the school prayer meeting. But why fits? Because there was jerking of the limbs and she was unconscious. But actually, it is a syncope. Jerking of the limbs does occur in syncope also. So jerking does not mean the patient has an epilepsy. So overdiagnosis, reason 4, mistaking jerking as a symptom of epilepsy. We should look into the totality of the picture, not just jerking of the limb. The child was standing for quite some time, and when we interviewed the person who was standing next to her, she gradually sank to the ground and had a few jerks. Now, how do you differentiate a syncope from seizure? In the last class, transient loss of consciousness, I have already discussed about the syncope part. Syncope occurs, usually it is a trigger, standing upright, looking at the blood or needles. Patient gradually sinks to the ground. Remember the word syncope, patient gradually sinks to the ground. Whereas in seizure, there is a sudden onset with sudden fall to the ground. Now, as soon as the person falls to the ground, the heart and the brain will come to the same level and quickly the patient recovers within 10 to 30 seconds. Whereas a seizure continues, tonic-clonic seizure, coma, postictal, all that things. Convulsive jerks are a few. Here it is very prominent. Incontinence, tongue bite, this and postictal confusion do not occur in syncope. Now, all these are only from the history. But all syncopes are not like that. For example, a 65-year-old male had episodes of unconsciousness with tonic-clonic seizures 2 to 3 months per month for 2 years. Multiple EEGs, brain scans, and multiple anti-epileptic drugs. Still, the patient continued to have the problem. Now, when I took more detailed history, it showed that there is an evolution of episode of blurring, sweating, followed by gradual fall, subsequent loss of consciousness, at times culminating in tonic-clonic seizure. This is a typical syncope symptoms followed by seizures. Now he's a 65-year-old man, so you should think of cardiogenic syncope. And then the patient had Stokes-Adams syndrome. These are seizures, but not epilepsy. Now, above the age of 60 years, whenever you see new onset seizures, first time seizure occurring after 60, 20% of them are cardiogenic syncope, requires detailed cardiac evaluation, heart block, cardiac arrhythmia. Just ordering Holter for 24 hours does not give us complete information. We may have to put a loop recorder for 1 week or even 1 month to catch the episode of syncope causing seizures. Now that was another reason, a cardiac syncope mistaken as epilepsy. It actually happened to one of my colleague's father, and for 2 years he was on anti-epileptic drugs, obviously with no relief. Now look at the other patient. A 20-year-old girl was found unconscious in the bathroom after she finished bathing. Why did I use the word after? Because there is a condition called as hot water epilepsy, which I will come to a little later. So after she finished bathing, the door was broke open because she had not come out of the bathroom. She regained consciousness after half an hour. Initially, we thought, of course, this is epilepsy, but then subsequent knowledge and information revealed that these are what is called as a gas geyser seizures. Typically, the bathroom is very small and ill ventilated. There is a gas geyser which is on, and the carbon monoxide accumulates because there is no ventilation, and the patient, before losing the consciousness, has suffocation. So if you get that history, she is suffocated, and after that she doesn't know what happened. There is a carbon monoxide gas geyser. Now, how do you make a diagnosis? History. Overdiagnosis, reason 5. We generally, all unexplained unconsciousness with total recovery, we make it as a epilepsy. I think that is the problem of overdiagnosis, reason number 5. So the next important paroxysmal disorder, which may be confused with the epilepsy, is a non-epileptic attack disorder. That is the right terminology used now. We used to call pseudo seizure, psychogenic seizure, functional seizure, etc. Now, this is one of my patients, a 14-year-old girl, had a new onset focal becoming generalized seizure in cluster for 2 to 3 days. And because it was a focal seizure, a MR scan was done, which showed a single neurocystic lesion. Patient was put on anti-epileptic drug. Follow-up MR scan was normal. Then I usually taper off anti-epileptic drug once the patient is seizure-free for 3 months and lesion has disappeared. But then there was recurrence of seizures after another month. I increased the dose. Again, seizures continued. Further increase in the dose. Then he came back again, sir, this time seizures are not coming under control. I said, record the video, record the seizure. And when he brought back the video record, it was a non-epileptic attack disorder. What was the overdiagnosis? Reason number 6, previous history of juvenile epilepsy made me to believe it is a continuation of the same. So whenever you find that the seizures are becoming more frequent in spite of good dose of anti-epileptic drug, all we have to do is record it on the video and view that. There's another girl of 25-year-old, new onset episodes of gradual fall to the ground, convulsive movements for 10 to 15 minutes. Gradual fall, you may think it is syncope, but in syncope you get a few jerks. The convulsive movements do not last for 15 minutes. And she was vocalizing, obviously not unconscious. Relatives brought her saying, sir, she has got epilepsy for the last half an hour. More detailed history showed it was a psychogenic seizure. Overdiagnosis, reason number 7, relying on history from one person. I took more detailed history from another person who was also an eyewitness. So the person take history from one more person who has witnessed the attack, then you will get more information. So history, history, and history. How do you differentiate a non-epileptic attack disorder from epileptic seizure? It is very simple in majority of the times, but sometimes it really focuses us. Now, a non-epileptic attack disorder is actually an attention-seeking disorder. So obviously it happens when somebody is in front of the person. It does not occur in sleep. It does not occur when the person is alone. And it is usually induced by a stress factor, and sometimes in the clinic we practice what is called a suggestion. So we usually ask the patient to lie down on the couch, close the eyes and put my fingers over the eyebrow, and ask the person to take deep breath and leave it, and tell the person that keep doing this, you will get a fix, then I'll be able to give you a proper treatment. And believe me, with suggestion, quite a few of them throw an attack. And the relative, when we ask, is this the attack which you see? They said, yes, of course, doctor, it is the same one. So you make a diagnosis of non-epileptic attack disorder. So it is often prolonged, occasionally even to hours. Patient will have hyperventilation during that time, retains consciousness. How do you know? The relative will say she was unconscious, but you ask whether she was talking something. How's ಡಾಕ್ಟರ್ ಹೇಳ್ತಾ ಇದ್ರು, ಅಮ್ಮ ಅವ್ರು ನೋಡು ಹೆಂಗ್ ಮಾಡ್ತಾರೆ, ಅಮ್ಮ ಅವ್ರು ನೋಡು ಹೆಂಗ್ ಆಗ್ತಾರೆ. So it is that she was conscious because you ask more questions. Pelvic thrusting, back arching, erratic movements. They hold one leg because it is convulsing, the other leg will start jerking. Most important, very good important clinical sign is that in non-epileptic disorder, the eyes are closed. It is 90% accuracy. Whereas in epileptic seizure, the eyes are open. So if you ask the person to record an attack and also ask the person to watch whether the eyes are open or closed, they'll say, no, doctor, the eyes were closed. I said, try to open the eyes. When they try to open the eyes, there is a resistance to the opening of the eyes because the patient is not unconscious. Whereas in epileptic seizure, the eyes are open and there's no question of trying to open it further. So this is a very important clinical point to differentiate a non-epileptic from seizure. And tongue bites are common in epileptic seizure, it never occurs in non-epileptic attack. So sometimes I ask the patient's relative whether she had a tongue bite because it's a very important clinical symptom. Then they say, how the doctor a tongue bite agittu? I said, where is a tongue bite? Then the relative will show the tongue being protruded out and then it is caught between the teeth. Now that is not the tongue bite. The tongue bite occurs on the lateral surface. So sometimes the non-epileptic patients will put out the tongue and keep it between the teeth, but don't bite. There is no self-injury. So all these points have to be looked into. Now, finally, as a physician, you may be sometimes confused with a transient ischemic attack from a seizure. Transient ischemic attack, by and large, is negative phenomena. So there is no convulsive movement, whereas in epilepsy, it is a positive phenomena. In TIA, there is an entire one half of body is suddenly affected, whereas in epilepsy, it spreads from one part of the body to the other. Then other problems will not be there. So it is not very difficult to differentiate TIA from epilepsy. Now, we have seen all this all the time now, overdiagnosis, overdiagnosis, overdiagnosis. Remember, 30% of epilepsies are overdiagnosed. That means it is not epilepsy, but it is diagnosed as epilepsy. Paradoxically, the investigations have contributed to overdiagnosis because you usually think that you make a investigation and you will get the confirmation or refute the diagnosis. As I said, why? EEG may show some abnormal rhythmic discharges, which is something like a non-specific STT changes in ECG. Similarly, we have many non-specific changes in the EEG. If that is interpreted as epileptic discharges, then you may call it as an epilepsy. Similarly, calcified lesion, lacunar infarcts have been taken in as a diagnostic of epilepsy. That is how they overdiagnosis. 20% of people on anti-epileptic drugs do not have epilepsy. Do you understand the implication? They're all on anti-epileptic drugs for 2 to 5 years, but they don't have epilepsy because of overdiagnosis. And most important, 20 to 30% of patients refer to epilepsy centers as cases of intractable epilepsy. After tremendous amount of investigations, they find they do not have epilepsy. So please remember, there's a lot of overdiagnosis of epilepsy. What happens if you overdiagnose? Let us see the consequences of misdiagnosis or overdiagnosis of epilepsy. The patient is subjected to unnecessary and prolonged medication for 2 to 3 years. And there are a lot of lifestyle restrictions. We tell them no driving, no swimming, at least for 1 year from the last attack. But there are more restrictions from family members because they are worried when the husband goes out on a tour, some other state or country, if he loses consciousness, who is going to look after? And the parents are worried. The young girl goes to the college and goes to the mall. If she loses consciousness and falls on the road, what will happen to her? I mean, it is a tremendous amount of tension for the family. And the person herself or himself, loss of self-esteem, because you can't do this, you can't do that, you can't do that, they go into a depression. If you tell a child has epilepsy, they don't get a admission to the school. It affects the sports activities. Of course, it affects the matrimony. Look at the entire range of problems for a patient who is diagnosed as epilepsy. And lastly, stigma. The person and entire family is devastated. The moment you say, okay, your daughter has epilepsy, the whole family gets collapsed because they are worried who will marry. So I'll tell you an example of one elderly lady of 65 years who had seizures for the first time in life. So I told her I will have to see whether it is a part of an epilepsy or not. We'll wait. Then she immediately started crying. I said, why are you crying? You are already married. You are a grandmother. No, doctor, I am not bothered about me. I would have preferred cancer, not epilepsy. I said, why? If somebody comes to know that in our family there is epilepsy, how will my granddaughter get married? That is my concern. Look at the stigma attached to the diagnosis of epilepsy. So please be very careful to make a diagnosis of epilepsy. Okay, now first step we said it is a seizure. It is not syncope, it is not non-epileptic. Next is it provoked or unprovoked seizure? What do you mean by provoked seizure? See, the cerebral cortex is highly irritable. So anything and everything, a physiological disturbance or a structural disturbance of the cerebral cortex immediately produces a seizure. The deep white matter does not produce seizure. It is the cortical mantle which produces the seizure. There are so many causes of provoked seizure. During my earlier days, all febrile seizures was treated as epilepsy. A child of 1 year having a febrile seizure was given 5 years of phenobarbital. In those days, only phenobarbital and phenytoin were available. But gradually, with improvement in understanding, we now find out that febrile seizures are provoked by sudden rise of temperature, not the degree of temperature, sudden rise of temperature. And so we address the fever and it is not epilepsy. A man of 40 is brought to casualty with a cluster of seizures occurring since afternoon. You may think that it is cluster of seizures, may go into status and admit in ICU. Then ask for the history. Oh, there is a fever for the last 3 days. Then you make a diagnosis of encephalitis. A little more history. This person was drinking every day, and with fever coming in for the last 3 days, he has stopped drinking, and sudden withdrawal of alcohol has caused withdrawal seizures. Again, this is not epilepsy. And any number of metabolic encephalopathies, hypoglycemia, hyponatremia, renal and hepatic failure. Patient gets admitted for seizures, then you admit and then find out that seizures are because of hepatic encephalopathy, then you stop anti-epileptic drugs. So these are all physiological disturbances which can cause seizure. What does this mean? These patients do not get anti-epileptic drugs at discharge from hospital. There are structural lesions also, like cerebral cysticercosis, pyreencephalitis, stroke. At the onset of stroke, there will be a seizure, or a person falls from scooter has a seizure. Now, these are all cerebral causes. Even these are not epilepsy, these are provoked seizures. Now, for structural lesions, we give anti-epileptic drugs for 3 to 6 months after discharge from hospital. If there are no further seizures, we taper it off. For physiological systemic disorders, when a patient has seizure, we give IV lorazepam. It is an anti-seizure drug. It is not anti-epileptic drug. So once make a diagnosis properly, at the time of discharge, we don't give any further anti-epileptic drugs. Again, what is the cause for overdiagnosis? Because all these provoked seizures are overdiagnosed as epilepsy, and they are advised to continue treatment for 2 to 3 years. So remember, seizure, all right, provoked seizure is not epilepsy. Now, this is a very common problem, hypoglycemic seizures. A diabetic took morning dose of insulin but did not take breakfast, as he had a fight with his wife, went to office without breakfast, had a seizure in office, brought to casualty. So because of the seizures, we give lorazepam to terminate the seizure. A GRBS showed 30 milligrams and the diagnosis of hypoglycemic seizure, no further anti-epileptic drugs. Occasionally you find other reasons, like one of my patients, a 40-year-old man, he had episodes of altered behavior for a brief minute followed by a generalized tonic-clonic seizure, 5 to 6 episodes in 1 year. He had several EEGs, brain scans, anti-epileptic drugs, 3 years, no effect. You remember, the patients and the relatives, they come with a complaint of what really bothers them. They don't tell all this. They will tell patient had seizures, and you concentrate on seizures. And EEG scan normal, then put on antiepileptic. So detailed history revealed. First, the patient had. You ask the patient before you lose consciousness, what did you find? What did you feel? Ella doctor, I just lost consciousness. I said, don't tell that. Sometimes you must be having a warning. Then they will think and say, yes, there is a dizziness, profuse sweating, palpitation, followed by altered behavior and seizures. Now, this is very typical of hypoglycemia. He's not diabetic. He's not on anti-diabetic drugs. So I said the initial features for hypoglycemia, I said, get a blood sugar done during the episode, not when he becomes fully conscious. Then you find it was 20 milligrams. He was diagnosed as hypoglycemia. Further investigation showed he had insulinoma. These are not common, but whenever you find you have made a diagnosis of epilepsy, but patient is not responding to the anti-epileptic drugs, sit back, think. The best investigation is taking the history once again. Another patient of mine, a 28-year-old, had a generalized seizure of 6 months duration. I had put him on phenytoin. One day he came to my OPD with this. He said, sir, I don't have epilepsy, but look at this, I'm not able to make this hand straight. I said, my God, this is carpopedal spasm. Got his calcium, phosphorus, alkaline phosphatase. The final diagnosis is hypoparathyroidism. No amount of anti-epileptic drug will help. So again, there are seizures, but not epilepsy. Recently added to this long list is one of my friends from St. John's. He has come out with a diagnosis of aromatic oil-induced seizures. Now, when a person comes with history of seizure first time in the life, ask more details. Your child patient had some cold and cough, and then he had a seizure. But in between, they have not told the story. Then you ask what else they have done. The usual thing, doctor, we applied some amrutanjan and eucalyptus oil inhalation, amrutanjan on the forehead and on the chest, and within 5 minutes, the patient had seizure. They will tell you about headache, fever, cough. They will tell you about the seizure. The in between is not told because they don't think it is important, and neither we thought it was important until recently after being published in an epilepsy journal. So now anybody who comes with mild headache, fever, and a seizure, ask whether the patient had any of the aromatic oil induced, like Vicks vapor rub or inhalation of the Amrutanjan, or any number of them are there. So what is the diagnosis here? It is aromatic oil induced seizure, but not epilepsy. I was talking to you about the hot water epilepsy. So during my earlier days, we used to do a house-to-house survey of Elandur Taluk with a idea of looking into the incidence of epilepsy and all. So we came across one 56-year-old male who had episodes of confusion, unresponsive, terminating into seizure, all during hot water head bath for 30 years. So in those days, we used to treat all hot water epilepsy as epilepsy, giving anti-epileptic drugs for 2 to 3 years. So we asked the wife, I said, why you have not consulted the doctor? She said, sir, why should I consult? I know how to treat. I said, how? I'll stand close to him when he is taking bath, and as he increases the speed to pour water, I just take away the bucket. No seizures. Fantastic native intelligence. And that is what we advise today. Hot water epilepsy, we don't give anti-epileptic drugs. We tell them to avoid hot water head bath. If a person wants to have a nice hot water head bath, especially a female with a lot of hairs and has to have a head bath with lot of shampoo and all that. So we tell them take one Frisium tablet 10 mg 1 hour before the scheduled hot water head bath. Look at her native intelligence. It is an epilepsy which is provoked by hot water on the head. And she knew how to do it. And now we tell the same thing. We learn from others also. So at the end of it, the provoked seizure is not epilepsy because it is provoked by systemic or cerebral causes. Reason for overdiagnosis number 8 is not recognizing it as provoked seizure, which we did. Febrile seizures we treated as epilepsy. Hot water epilepsy we treated as epilepsy. So now we ask for any provocation, including recent eucalyptus oil. Okay, after a lot of history, we said patient had definitely a seizure, and it was not provoked, it was an unprovoked seizure, but it was the first time in life seizure. It is a single seizure, but it is still not epilepsy because we need at least 2 seizures to call it as epilepsy. Why 2 seizures? Because a single seizure does not mean the patient is going to get more and more seizures in life. The recurrence rate is as low as 27%, in some papers to as high as 80%. So usually single seizure without any structural brain damage, without any other social issues, we do not give anti-epileptic drugs. But there is a rider in this. When they come for generalized seizure, you should ask for history of absences, myoclonic jerks, or complex partial seizure, small attacks of seizures, which has now terminated into a big attack. So if there is a past history of small attacks, then it is definitely in epilepsy. Okay, finally we have come to a diagnosis. It is epilepsy because patient had a seizure which was unprovoked and patient had 2 or more such seizures. Now we have made a diagnosis of epilepsy. But then you must know what is the type of epilepsy. So type of epilepsy will determine the method, will determine the medication. We go back to the classification: focal onset, generalized onset, unknown onset. Focal onset with impaired awareness is what is called as a complex partial seizure. Focal onset with awareness is focal motor seizures. So we have focal seizures, generalized seizures. I won't go into too much of time for generalized tonic-clonic seizures. All of you are aware. There is a cry, fall, loss of consciousness, tonic-clonic movement, lateral tongue bite, and all the works. Now, up till now, I have been telling you about overdiagnosis of epilepsy. Now we come to the other half, underdiagnosis of epilepsy. Why we underdiagnose? Because the patient doesn't have tonic-clonic seizures. So which are those epilepsy conditions which do not have loss of consciousness or tonic-clonic seizures? Absences in pediatric age group, commonest in adult, complex partial seizure, commonest in juvenile patients, juvenile myoclonic epilepsy. Why is it underdiagnosed? Because we are not aware of it, lack of knowledge. Even I remember when I was doing MD General Medicine, we didn't know any of these things because we were taught neurology by general physicians. Now you're all lucky. Each specialty is being taught by specialists in that particular field. So obviously we were never being aware of it. We didn't have a knowledge of it. So when I tell the patient, look, whatever you had a small attack is actually a minor type of fits. Then the patient will say, sir, ನನಗೆ ಗೊತ್ತೇ ಇದ್ದಿಲ್ಲಲ್ಲ ಇದು ಫಿಟ್ಸ್ ಅಂತ ಹೇಳಿ. So I said, ನನಗೂ ಗೊತ್ತಿದ್ದಿಲ್ಲ, ನಾನು DM neurology ಮಾಡಿದ ಮೇಲೆ ಗೊತ್ತಾಯ್ತು. Now abscences are very typical in pediatric age group. Abrupt onset, it may occur 10 to 70 per day, 5 to 10 seconds. Patient will be standing, unaware, eye blinking. Typical EEG shows 3 Hz spike and wave. In clinical practice, when you suspect abscences, we ask the child to hyperventilate. And the moment the child starts, there is a sudden stoppage of the breathing. The child will stand and have blinking of the eyes 3 per second. And the relative will say, this is how she behaves. So that is a diagnosis of abscences. Now, complex partial seizure, this is a patient where patient was not aware. Patient has come with history of giddiness occurring once in 1 to 2 weeks for the last 3 months. Then immediately you will give Vortin. Take more history. What is giddiness? What happens to you? I don't know, doctor. I feel giddy, but I don't remember. So I caught that word, I don't remember. I said, call the person who has seen you when you had giddiness. And when I took the history from the person, as she is talking, she goes blank, staring, unresponsive, chewing, champing, swallowing movements for several seconds, followed by confusion. She doesn't remember what she was talking about. I usually demonstrate the attack myself during the OPD. And when I show them the eyes staring, chewing, champing movements, they say, this is what the patient has. So that gives a diagnosis. It is complex partial seizure, but the patient did not have generalized seizure as yet. So they are all underdiagnosed. Now in pediatric practice, there may be confusion between absence and CPS. If it is an adult, there is no question of absence in adult. It is always a CPS. If it is a child, it can be there. See the difference. In absence, there is eye blinking, eyes close and open, whereas in complex partial seizure, the eyes will be staring, eyes open. The duration is 10 seconds and 30 seconds. There is a postictal confusion. And most important, you do hyperventilation for a child, you can elicit an attack of absence. There is another medical student who came with the history that she used to fall to the ground suddenly and immediately wakes up. I do not know why I am falling, and I am not unconscious. So 2 important points. So I said, as she's walking in the corridor in the college, she suddenly falls to the ground, and the colleagues will say, hey, enaito, and they will make her lift up, and then she starts walking and talking normal. This happened a few times, and so they came for a checkup. They thought it is a giddiness or syncope and all. In syncope, there is a gradual fall, whereas here there is a sudden fall. And the patient does not know why. While falling, she does not know. As soon as they fall, they become awake. So this is not syncope. And further history, I said, do you have any myoclonic jerk, especially morning after waking up? This is said, yes, morning while I am brushing my teeth, I get a jerk. While having a coffee, suddenly the coffee mug falls down. Now with that history, it is a juvenile myoclonic epilepsy. Patient did not have yet generalized seizure. That's why underdiagnosis. Now when we talk of jerks, the relatives come back next time and they say, doctor, my child when she is sleeping, or my daughter or husband when she is sleeping, they have myoclonic jerks. Is that epilepsy? They're called as hypnic jerks while falling. The jerks occur while falling asleep. That is from wakeful to stage 1 sleep. This is physiological. All of us have experienced when we are sitting in a chair and reading, suddenly the book falls down because you have a jerk of the hands, because from awake you are going into a early sleep stage. So this is a hypnic jerks, not epilepsy. Okay, now we have made a diagnosis and we have made a type of epilepsy. Finally, is it idiopathic, which most of our medicine is idiopathic, or is it a symptomatic of underlying brain disease? Nearly 90% of epilepsies are idiopathic. Only about 10% you will find a lesion in the brain which is responsible for the seizures or epilepsy. Now, how do we diagnose? It is due to an ongoing cerebral lesion. Ask the friend. Ask who is a friend apart from seizures. Who is the friend? Patient has symptoms of raised ICP, paresis, diplopia. Examination shows some neurological signs, papilledema, or it is a focal motor seizures. Most of the idiopathic epilepsies occur below the age of 25 years. So any new onset seizures after that, one imaging of the brain is required. So you can choose and ask for an investigation, not go straight away for MR scan. Do we have any investigation to confirm the diagnosis of epilepsy? Absolutely no. Epilepsy is entirely from the history, from the patient and the eyewitness. We have two important investigations. One is EEG, another is the imaging. Why do we do EEG? EEG will tell us whether it is a myoclonic type, absence type, complex partial type, or a generalized epilepsy. When a patient comes with generalized seizure, we ask for history, complex partial, myoclonic seizures, absences. History-wise, nothing is there. So you make a diagnosis of generalized epilepsy and try to give a medicine for that. But when you do an EEG, there is a EEG evidence of absence or JME or CPS. Then you change the medicine specific to this type of epilepsy. So that is the reason why we do EEG. When you want to make a diagnosis of epilepsy, EEG will not help, because some type of abnormal EEGs are seen even in patients, even in people without any neurological disease. When you suspect it is due to an ongoing cause like tuberculoma or tumor, then you do a imaging, otherwise not necessary. So there may be a meningioma or a cysticercus granuloma, and there is a focal epilepsy or epilepsy plus neurological symptoms or signs. So you have been listening to me diagnosis by history, history, and history. And sometimes history taking is a big job. Neither the patient nor the witness are cooperative to give details, or there is no witness, and the patient herself or himself is not a good historian. So what do we do now? Wait and watch. There is no hurry to start medication. Remember the effects of a wrong diagnosis. Don't know is a better diagnosis. You tell that I don't know what you have. When you have another episode, please come with all these details. Don't know is a better diagnosis than wrong diagnosis. Usually the doctors ask me, sir, if it is really an epilepsy, if you don't start anti-epileptic drug, the patient may get another attack. I said, right. When you start anti-epileptic drug, there is no guarantee that the person will not get another attack in the near future, because you need to titrate the medicine to stop the drugs, to stop the seizures. Now we come to the mismanagement. How do you manage an acute attack? That is, mismanagement is very common. What we recommend is, because they may choke, loosen the necktie or a tight collar to prevent injuries, remove the spectacles, and see that the patient, while having convulsions, does not hit any hard objects to injure himself or herself. You must educate the relative of the patient. Don't push anything in the mouth. They're always scared about tongue bite. So either they put a spoon or they put a kerchief or they put their finger into the mouth and the patient chews the finger, completely destroying the finger. Don't do that. Other thing they do is, still the patient is unconscious, they pour water. Again, they may choke into the trachea and they may even die. They think by holding the legs, they can stop an attack. The attack is coming from brain, you tell them. don't restrain the movement. And very commonly, people keep a keys in the hand. Well, at least this is not injurious like these things, but it is of no use. And they're always worried about tongue bite. When you say don't keep anything in the mouth, you tell them the tongue will not be cut into two halves. It is always a lateral border of the tongue which is injured, so there's nothing to be worried at all. Now I'll give you two case scenarios. Patient number one had a generalized seizure at home, brought to casualty by 10:30 a.m., that is 1.5 hours later. Patient is fully conscious, alert, no neurological deficit, no need to give IV lorazepam, no need to admit in ICU. If it is a new onset seizure, you may investigate him as an OPD. To prevent another seizure, you give fast-acting clobazam, sublingual, no need for IV lorazepam. But what happens? What is the mismanagement? Anyone with history of one seizure gets lorazepam, levetiracetam, and admission to ICU. That is a mismanagement. But suppose the patient, instead of one seizure in office, another seizure while traveling in the car. Now this patient can have a third seizure. This patient requires IV lorazepam given in 4 mg in 4 minutes. No need to give immediately levetiracetam, phenytoin, valproate because lorazepam acts for 24 hours. After lorazepam, if the patient has another seizure, then admission and any one of these IV medicines. So that is the management of an acute attack. One seizure, conscious, just give oral tablet and investigate as an outpatient. 2 or 3 seizures, give IV lorazepam, and after that a seizure, then you start Levipil or levetiracetam. Now, because the seizures are recurrent, the next treatment is to prevent the next attack. Now, what drug to give? Here is the important type of epilepsy. So unless you know the type of epilepsy, you don't know what drug to give. But in clinical practice, the moment there is a diagnosis of epilepsy, it is a knee-jerk reaction. Immediately they prescribe levetiracetam 500 mg BD, which I think is a wrong practice. Drugs to prevent the next seizure, these are the primary drugs, the older drugs, phenobar, phenytoin, carbamazepine, valproate. And for information of all of you, please remember these drugs are more effective as anti-epileptic drug than any number of new drugs. More effective as anti-epileptic drug, but all new drugs are being marketed saying that side effects of these are not there. But we don't choose a drug because it may produce a side effect. We choose a drug for a good effect. Now, in the initial stage, I told you that 70 to 75% of patients with epilepsy can be well controlled with the primary drugs. Another 20 to 25% are the one difficult to control with primary drugs. And there we have number of anti-epileptic drugs coming in the market. All these are for the 20 to 25%, not for the first 70 to 75%. Why drugs are going on increasing? Because the patients, about 25% of them still have seizures, though a good 75% have no seizures. No, 25%, suppose there are 1 million patients, 25% is 2.5 lakh patients. So that all this drug marketing is for that group. Now to re-emphasize my point that the primary drugs are the best, there are several studies. Valproate was compared with topiramate and lamotrigine, and it concluded that valproate should remain the drug of first choice for many patients with generalized and unclassified epilepsy, published in Lancet. There is another drug, Journal of Neurology, Neurosurgery, Psychiatry in 2013, where levetiracetam was compared with valproate and levetiracetam was compared with carbamazepine. In newly diagnosed epilepsy, levetiracetam is not superior to standard anti-epileptic drug. As recently as June 2019 in International Epilepsy Congress, one more trial was held in UK. Levetiracetam is inferior to valproate in generalized and unclassified epilepsy. So please remember the primary drugs are the best drugs to be given. Valproic acid in USA, of course, in addition to valproic acid, they also use lamotrigine. You look at this, valproic acid, carbamazepine, phenytoin, valproic acid, valproic acid, valproic acid. If you look at valproic acid, it is there in primary, partial, absence, atypical. So valproic acid or valproate is the broad spectrum anti-epileptic drug. So when you don't know how to classify the epilepsy, best thing is like broad spectrum antibiotic which we use when we don't know which is the bug which is there. Antibiotic, broad spectrum anti-epileptic drug is a valproic acid. From clinical practice point of view, my suggestion, generalized seizures, all four primary drugs are good: valproate, phenytoin, phenobarb, carbamazepine. When you don't know whether it is really generalized or some type of JME or absence, use valproate. When it is a simple partial, you can use phenytoin, carbamazepine. Complex partial, carbamazepine. Complex carbamazepine is the drug of choice for complex partial seizure, notwithstanding the number of anti-epileptic drugs. Abscesses and JME, there is only one drug. The drug of choice is valproate. Please remember. And to further emphasize why you should use the primary drugs, look at the knee-jerk reaction of prescribing Levipil 500 mg. Each tablet is about 13 rupees. Per day it costs 24 rupees and patient has to take treatment for 2 to 3 years. And look at carbamazepine or valparin. The cost difference is enormous. And I see patients who are children of auto rickshaw driver or daily laborers not taking their food in the night because they have been prescribed Levipil. They says, doctor, all my earnings goes in the treatment for my child. Please remember, when you prescribe any drug, any antibiotic, any medicine, look at the cost. Don't just blindly prescribe the drug. So there are many reasons why you should stick to the primary drugs. And when you start, don't start with 500 mg BD. Start low dose and gradually increase it. If the first drug fails, of course, you please look at your diagnosis. Is it a juvenile myoclonic epilepsy? Have you used carbamazepine? Then it worsens these seizures. So check the right diagnosis and the right drug for it. In my practice, because most of the patients are on levetiracetam and complex partial seizure are the one which are resistant to levetiracetam, all I have to do is switch them back from levetiracetam to carbamazepine. If it is a idiopathic generalized epilepsy, levetiracetam to valproate. Cost is less and they get an excellent result. The result of ubiquitous prescription of levetiracetam. Clobazam, something about clobazam. When the first drug fails, so what is the add-on therapy we do? Suppose complex partial seizure, you start on carbamazepine, 200 mg BD. Then you increase it to 200 mg, 400 mg, then 400, 400. So you keep on increasing the dose. Once you know it is complex partial seizure, you know that carbamazepine is the drug of choice. Once you know that this road leads to Bombay or Mumbai, you keep on going. You don't stop and take another deviation. So that drug has to be increased, looking at clinical toxic effect. Don't depend on anti-epileptic drug essay. If the patient has diplopia, ataxia, drowsiness, then you know that the dose is quite high for that patient. Then you have to add a second drug. Now the common second drug we all use in practice is clobazam. Clobazam, it came as a tranquilizer, but it has got a lot of use in as epilepsy. It's a broad spectrum anti-epileptic drug used in focal epilepsy, complex partial, generalized epilepsy. It can be added to any one of the drugs. There is no enzyme induction or inhibiting properties. It does not change the level of other drugs. There is no clinically meaningful drug-drug interaction. So very safely, complex partial, give carbamazepine 6 tablets a day. Still the patient has attacks. Then you start clobazam 10 mg HS. More important, clobazam is the fastest acting oral anti-epileptic drug. As I told you, in the emergency, if the patient comes with one seizure, you give oral clobazam because it acts within several minutes. So we make use of this clobazam in what is called as a situational seizure. Now in febrile seizures, First thing is to bring down the temperature, and for the next 48 hours, we give clobazam in a child 2.5 mg BD for 48 hours. Hot water epilepsy, if somebody is very keen to have hot water, prevent epilepsy 1 hour before give clobazam. Catamenial epilepsy, some patients have seizures coming around the ovulation period. So 2 days before and 2 days later, we use clobazam. Sleep deprived states. Many of my IT patients who travel abroad, they all have sleep deprivation in the night because they have to catch flights in the late night or early morning. And lack of sleep is one such provocating factor in a person with epilepsy. So we give for overnight bus journey and all, ask them to take clobazam 10 mg at 10 p.m. in the night and then go to the airport at 2 a.m. or 4 a.m. Honeymoon phase is another one where obviously the sleep deprived states, let them enjoy their life, but let them take clobazam for the first 1 week or so. So these are the tremendous uses of clobazam. So what I do in practice, uh, carbamazepine plus clobazam or valproate plus clobazam. When that doesn't work out or the patient has problems of side effects, then you start using any one of the other add-on drugs. A couple of slides on epilepsy and women. When I started practice, we used to give valproate for all the patients of JME, which is still now it is the best drug for juvenile myoclonic epilepsy. And among all the anti-epileptic drugs, the valproate has got more amount of the fetal malformations. I'll come back to it 1 second. Yeah. The major congenital malformations like spina bifida and meningomyelocele occurs in general population without any drugs, without history of epilepsy, 1.6 to 3.2%. If the patient is on anti-epileptic drugs, the risk is 3 to 4%, and it becomes 9% if there are more than 2 anti-epileptic drugs or when valproate is more than 800 mg per day. So generally, when a patient has JMA, juvenile myoclonic epilepsy or epilepsy, and they are looking for matrimonial alliance, we look into it. And suppose the patient is already 2 years seizure free, we withdraw the drug and ask them to wait before conception. And if the patient is on uh, getting frequent episodes, then try to give a single drug along with 5 mg of folic acid. Up to 800 milligrams of valproate is safe, but don't give in a single dose. Break it into 200 milligrams 3 or 4 times a day. And to look for malformations, we have investigations by like serum alpha fetoprotein at 16 weeks and ultrasound at 18 weeks of pregnancy. And we should insist that the anti-epileptic drug should be continued throughout pregnancy, delivery, postpartum. There is no problem for breastfeeding. It's an extremely important point. 70 to 75% are well controlled with anti-epileptic drugs, but there is a good 25 to 30% who are still not controlled. Of them, half of them can be well controlled with surgical treatment. There is another 15%, in spite of medicines, in spite of surgery, they continue to have seizures. And most often they are patients with a brain damage, perinatal brain injury, severe head injury, post-encephalitis. These are the patients who have drug resistant and not surgically fit candidates. Let us concentrate on this large group of patients who can be well managed by any physician, primary care physician, consultant physician, or a general physician or a surgeon or anybody for that matter, if you follow the basic principles. So when should we withdraw a drug? Earlier we used to say everybody 5 years seizure free period. Now a great majority of them 2 years if they are seizure free, we start tapering the drug. Mark the word seizure free. Usually they will come back after 2 years after my first consultation. Doctor, ನೀವು ಹೇಳಿದ್ರಲ್ಲ 2 ವರ್ಷ ಅಂತ ಹೇಳಿ 2 ವರ್ಷದಿಂದ ಫಿಟ್ಸೇ ಇಲ್ಲ. When you ask them myoclonic jugs, ಅದು ಬರ್ತಾ ಇದೆ ಡಾಕ್ಟರ್, ಅದರಿಂದ ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ. Complex partial seizure, oh, that is also there. Then they are not really seizure free. They are generalized tonic-clonic seizure free. If you withdraw, they will start getting generalized seizures. So insist on seizure free for small and big attack. Withdraw one drug at a time, once in 2 to 3 months. And they all ask whether, do you give guarantee that my daughter will not get another seizure? I said, in my profession, there is nothing to guarantee. I can only give you the statistics. 5% GTCS, there is a recurrence. There's a 30% of the chronic complex partial seizures. But remember, 70% of CPS will go off the drugs. So let us look at the positive aspect. In clinical practice, I see physicians and neurologists starting anti-epileptic drugs prophylactically. The moment there is a stroke patient, even if they did not have a seizure, they start on anti-epileptic drugs and discharge, and they will continue anti-epileptic drug for another 2 years. Head injury, no seizure, just head injury. Tuberculoma, tumor, there is no need for prophylactic anti-epileptic drug. This is not me telling, this is the literature. Now I told you what are the consequences of overdiagnosis of epilepsy. Now these are the consequences. In clinical practice, it is very easy to control seizures. 70 to 75% seizures are well controlled. But 100% of these people, not only the patient, the entire family, they suffer from the problems of social aspects because of myths, prejudice. This is the thing which really kills the patient and the family. It is not the seizure. It is not the seizure. Now, there are so many questions which you also should know as a physician to answer them correctly. I keep telling them, look, a person with epilepsy is completely seizure free. Completely seizure free. During that period, between the two seizures, patient is totally normal unless there is an ongoing brain disease. 3 months back, one seizure, and yesterday, one seizure. In between, the person is totally normal. So they can lead a very normal life like anybody else. They can go to school, college, they can go for employment. Driving and swimming, 1 year, it's not permanent ban. 1 year of seizure free period. After that, also, if they have to continue anti-epileptic drug, driving or swimming is not banned. In US and UK and Singapore, once the person is seizure free for 1 year, they may have to continue anti-epileptic drug for another 2 years, but they are allowed to give officially a driving license. Travel, pregnancy, fruits, food, music, sports, marriage, computer, TV, everything is allowed. People say, oh, he has to do a lot of work on computer. Who is not doing work on computer? Computer, watching TV does not cause it. All this education has to be done. Otherwise, in our country, everybody is a doctor except the doctor. So the wife, the mother, the grandmother, the neighbor, the bhajiwala, everybody will give you advice. Balahan tin battery, TV note battery, sports go battery, and all that. The final word, what we have is actually it is not an anti-epileptic drug. Please remember, we keep on using the word anti-epileptic, but it is not anti-epileptic. It is only anti-seizure drug. We are yet to find a true anti-epileptic drug, either a disease-modifying drug or a true anti-epileptic drug. EEG, I think I have no time for talking about EEG, maybe some other time. And at this point of time, I'm stopping the recording, and then I will